Hello, my name is Dr. Adriana Lazarescu, and I am your host today for GI 101. In this podcast series, we discuss common motility disorders that affect the digestive system. Recently, I sat down with Dr. Dan Sadowski. Dan is a gastroenterologist at the Royal Alexandra Hospital in Edmonton, Alberta, and he has an interest in eosinophilic esophagitis. I wanted to find out more about this condition because it seems like it is becoming increasingly more common. As you will soon learn, there are some new treatment options available. Here, then, is my conversation with Dr. Dan Sadowski. Hello, Dan. Welcome back to GI 101.
Thanks, Adriana. It's really good to be here again.
So today, I would like to update our listeners on eosinophilic esophagitis, and perhaps we can start by talking about what this condition is and how it comes to clinical attention.
Okay, so eosinophilic esophagitis, or EoE for short, is first of all an immune-mediated chronic inflammatory condition of the esophagus. And the hallmark finding is the infiltration of eosinophils into the mucosal layers of the esophagus. And this inflammation can lead to fibrosis in the wall of the esophagus with stricture formation and difficulty swallowing. And for some reason, young men are commonly affected. And a common presentation is a young male coming to emergency with a food bolus impaction in the esophagus. And when I get that phone call, I know that the diagnosis is likely to be EoE.
You mentioned that this is an allergic immune-mediated disease. Can you talk more about that?
Yeah, so we believe that EoE is probably a dysfunctional immune response to environmental allergens, food antigens in particular. As well, we know that patients with EoE often have a variety of other atopic-related allergic conditions such as eczema, asthma, and chronic sinusitis. And for some reason, all of these conditions, including EoE, seem to have a rising prevalence in our society today. And the reason for this is still poorly understood.
Okay, so how is the diagnosis of eosinophilic esophagitis actually made?
Well, one can have a high index of suspicion. For example, a 20 to 30-year-old presenting with mechanical sounding dysphagia and repeated episodes of food impaction. And by mechanical dysphagia, I'm talking about difficulty swallowing solids more than liquids. And by the way, if any of our listeners want to learn more about how to assess a patient with dysphagia, we actually cover that topic in a previous episode of GI 101. In addition to dysphagia, patients sometimes will also present with chest pain or refractory reflux symptoms. These, in the setting of other allergic disorders, should make one highly suspicious of EoE. However, the only way to confirm the disease is with endoscopy.
Okay, so what would one expect to find on endoscopy?
Well, the endoscopic findings are actually classic. We can see longitudinal furrows, mucosal edema, white exudates, transverse ridging, and often frank stricturing and luminal narrowing in the esophagus. Biopsies are definitive, and pathologists will routinely count the number of eosinophils per high-power field. And if there are more than 15 to 20 per high-power field in both the distal and proximal esophagus, the diagnosis is confirmed.
Are there any other conditions that might mimic these findings?
Well, the important condition to rule out is gastroesophageal reflux disease, or GERD. GERD can produce inflammatory changes in the lower esophagus, including eosinophils, on biopsy. That's why it's important to take biopsies from both the lower and upper esophagus. EoE will have eosinophils in both the lower and upper esophagus, while GERD tends to have predominantly infiltration with eosinophils in the lower esophagus.
Let's talk about treatment options for EoE, Dan.
Yeah, so potential treatment options include the use of proton pump inhibitors, oral topical steroids, and elimination diets.
Let's start with the proton pump inhibitors.
Okay, so PPIs, as you know, have a potent ability to suppress gastric acid secretion, and this is why they're so useful in the treatment of conditions like gastroesophageal reflux disease. But in EoE, the effect on the disease seems to go beyond acid secretion, and there appears to be a direct effect of the PPI on the inflammatory response generated by eosinophils. So, my current treatment regimen is to begin with a course of a PPI, such as pantoprazole, 40 milligrams twice daily, for a period of 8 weeks. And because symptoms are a rather unreliable indicator of disease activity, I normally rescope the patient and rebiopsy to ensure that there is histologic remission. And histologic remission is defined as an eosinophil count of less than 15 per high power field. And approximately 40 to 50% of patients will actually respond to PPI therapy alone.
If a patient does not respond to PPI, what are the next steps?
In my practice, the next step is oral topical steroids. And for this, the most common steroid is budesonide. And budesonide is a rapidly metabolized steroid which has less systemic side effects than prednisone, for example. The starting dose is 2 milligrams per day. Now, most published clinical trials used 1 milligram twice daily, but most patients find it easier to take 2 milligrams all at once at bedtime.
How do you get the budesonide to coat the lining of the esophagus?
Yes, and this is where it gets a little complicated. The patient can't just simply swallow the budesonide into the stomach, as this will have little effect on the inflammation in the esophagus. The key is to deliver the medication in such a way that it is applied topically to the entire length of the esophagus. And typically, the pharmacy will dispense the budesonide mixed in a viscous gel that the patient can aspirate into a syringe to measure the dose, or budesonide ampules are given that can be dispensed for the patient to open and mix with a solution such as Splenda. However the patient takes the budesonide, it's important that they do it on an empty stomach, and then they not eat or drink anything for about a half an hour afterwards to allow the drug to be absorbed topically.
Sounds like a rather messy process.
Yes, the shelf life of budesonide in viscous gel is only 30 days. And so it makes it difficult for patients who live far away from pharmacies or they want to travel. And for that reason, recently there's been the development of an oral dispersible tablet. And the coating of the tablet is designed to release the budesonide granules down the length of the esophagus. It's definitely an improvement over the hassle involved with taking budesonide in liquid form. Now, this medication is available in Canada under the trade name Jorvesa, and it comes in 1 milligram and 0.5 milligram tablets.
Okay, what about the use of certain asthma medications for EoE?
Yes, some practitioners will use fluticasone inhalers, marketed in Canada as Flovent, and this is a commonly used steroid for asthma. But instead of inhaling the drug, it is squirted into the mouth and swallowed. And the dose for active EoE is to use the 250 microgram inhaler 4 puffs twice daily. I tend not to prescribe this treatment as patients find it awkward to use.
You mentioned earlier that EoE may be an allergic reaction to dietary food antigens. Is there any role to allergy testing in EoE?
Yeah, that's an excellent question, and there have been a number of studies that have looked at various allergy tests, for example, a pinprick skin testing, cutaneous patch testing, and also IgE levels to certain antigens. And unfortunately, none of these tests seem to be predictive for which food antigens are actually causing the disease. And so the current recommendation is to actually not perform these outside the setting of a clinical trial.
Okay, that's good to know. Is there any role for dietary therapy in EoE?
Yes, in children, there is good evidence that a strict elimination diet can induce clinical remission. The diet often used in kids is the 6-food elimination diet, which consists of eliminating milk, eggs, soy, wheat, tree nuts, and fish. And while you can do a strict diet like this in children, because it is a dictatorship after all, adults have difficulty adhering to a strict diet like this. And so there have been attempts to only eliminate the most common food triggers for EoE. And so a common approach in adults is the 4-food elimination diet, which consists of milk, egg, soy, and wheat elimination. In both adults and kids, once remission is achieved, foods are added back in sequentially until the trigger food or foods are found. I have to say that in my practice, I have not had too many patients actually able to control symptoms with elimination diets alone. And so I tend to use mostly pharmacological therapy for EoE. But for those who are motivated and who want to work with my dietitian, I definitely present this as an option.
Okay. Well, thank you, Dan. That was an excellent review of this important topic. I'm especially glad to learn that there are some newer therapies available. That is it for this week on GI 101. Stay tuned for more episodes. See you again soon. Bye.
Bye.